So good afternoon, everybody. We will introduce ourselves first of all. My name is Christina Federico. I'm one of the dietitians working within the neuroscience dietetic team at Salford.
Hi there, I'm Kerry Harris, one of the Band 5 dietitians, rotational, and I'm currently based in neurosciences, mainly based in stroke.
So together, Kerry and I today are going to talk about the subjects of nutrition and stroke. So just to give an overview of what we will cover in the session this afternoon, we thought it'd be helpful to give some background evidence that we have with regards to nutritional risk in the stroke population. So predominantly looking at the subjects of malnutrition and dysphagia. We'll give a recap and talk through some of the national standards that we refer to when we're benchmarking nutritional care. Within that, we'll touch upon a little bit to do with secondary prevention advice that perhaps is more relevant for sort of more of the rehab and community side of the patient journey. And then the second part of our presentation is we're going to share today our experience from Salford with regards to some recent work we've conducted where we formed a stroke-specific nutrition pathway and share results of a quality improvement project that took place last year. And within that, we'll touch upon some of the evidence around long-term feeding in stroke patients.
Yeah, great. So I'm just going to talk briefly kind of about the importance of nutrition post-stroke, and how we fit in. Mainly kind of the high risk of malnutrition and dehydration in stroke patients, unfortunately. So up to 25% of patients who are malnourished will then go on to become more malnourished after a few weeks. And malnutrition following stroke is reportedly present in up to 62% of patients, and unfortunately related to poorer clinical outcomes. And also alongside that, dehydration is a real concern, and we'll talk about it a little bit later, but particularly on often a textured modified diet and thickened fluid, it's really hard to get enough fluid on board to meet needs, and that's, as I say, often related to dysphagia, and again that's linked with poorer clinical outcomes, unfortunately. So causes of undernutrition, various reasons, to be honest, we tend to find, but causes include dysphagia, so as mentioned, textured modified diet and fluid. It can be really hard in textured modified diet to get sufficient nutrition on board. Delays or disruptions in enteral nutrition, for instance, whether they've been waiting for a best interest meeting, or whether the NGs become displaced and they're waiting for kind of replacement. Levels of alertness and reduced ability to self-feed, and other practical barriers on the ward, potentially some staffing issues, lack of maybe support staff to help with feeding can be really problematic. And if these problems of undernutrition can last for kind of weeks, if not months, often patients might be down on the rehab unit for several weeks and months, and this can lead to longer term kind of issues of malnutrition if not monitored and managed appropriately. And malnutrition related to increased risk of infection and mortality, unfortunately, things like impaired wound healing, muscle wasting, and inevitably, unfortunately, longer hospital stay and more complex discharges, and also higher treatment costs and reduced quality of life. And in terms of how we kind of like to emphasise and how we fit in, just to highlight really that stroke patients are a really vulnerable patient group. In terms of nutrition, they're often catabolic, particularly if they've had a hemorrhagic stroke, they've got higher nutritional needs, and it can be really challenging to meet nutritional needs on things like a textured modified diet. So they're really vulnerable and at risk of malnutrition. And then also fitting in there with the work of physios and how important nutrition is, maintaining nutrition for rehab potential. So for instance, if someone is losing weight rapidly, they're undernourished, unfortunately this kind of might impact on their ability to undergo rehab. So Christina, next slide, is that okay? Oh, sorry, next slide, assessing nutritional risk. So how do we identify nutritional risk? The MUST score, MUST tool, we'll talk about in the next slide. That tends to be the first go-to nutritional screening tool, which is a bit of a step-by-step screening tool. Regular weight monitoring, so it tends to be weekly, if not bi-weekly. If it's someone that's particularly vulnerable, we tend to hopefully advise. And then linking in with nutritional care plans. So it might be that the popped on like an initial care plan until a dietitian's seen the patient, but certainly referral to a dietitian as soon as possible, as Christina will talk about a little bit later. And then community agreed local tools, and this is just a link here to actually a really handy self-screening resource that can be accessed in the community. Yep, so as I mentioned, this is the MUST screening tool. As I say, it's a step-by-step screening tool. So it looks at, if you're not familiar with it, it kind of fairly straightforward. It looks at BMI score, weight loss, and then acute disease effect score. There fortunately can be some areas of fewer limitations here, to be honest. So often kind of maybe patients are overlooked if the BMI is healthy or they're overweight. Weight loss may not be considered. It's often difficult to find out how much a patient's maybe lost weight-wise prior to admission. Step 3 can cause some confusion because often patients are put nearby mouth on admission, and there's uncertainty around how long this might be. So just a bit of a take-home really. This shouldn't be used in isolation, and do always kind of access advice from a dietitian and others if unsure about this. So onto dysphagia. I think I mentioned earlier about this patient group being really vulnerable, largely due to the prevalence of dysphagia, which is really high in this patient group, unfortunately. So it's reported to being up to 78% of patients immediately post-stroke, and 81% of patients will present with initial dysphagia. Were found to have persistent swallowing difficulties at 6 months. Yep, and then just a slide here about the clinical consequences. I won't run through them all in detail, but just a few of them. As I say, things unfortunately, aspiration. 52% of patients with dysphagia suffer from aspiration, and then that can cause a knock-on effect, can't it, in terms of nutritional recovery from that, and things like aspiration pneumonia, choking incidents, unfortunately increased risk of mortality. And as I've mentioned, from a nutrition and dietetic perspective, dysphagia can unfortunately lead to weight loss and malnutrition. It's often hard to kind of manage on a texture modified diet, and also an energy feed, whether there's been periods of the energy coming out, going back in. Unfortunately, it can be difficult to optimize nutritional intake. Yeah, and this is the ITSE framework. If you're not familiar with, this is an internationally agreed framework, just a global standard, to be honest, which helps with the communication on the ward with the different levels. So a bit relatively easy to kind of understand and use, but however there can be a bit of confusion on the ward sometimes with as I say, it's relatively new, been updated, and also just taking care with nutritional supplement drinks. There are specific dysphagia specific ones, so sometimes there needs to be a little bit of education on the wards about giving certain supplements to certain kind of patients. There sometimes has been found that non-dysphagia supplements are thickened and things like that, so it's just been a bit careful that the correct feeds and oral nutritional drinks are prescribed as per the dietitian. So moving on to considerations with dysphagia management. Unfortunately, there are a number of challenges really in terms of dysphagia management and optimising nutrition, particularly as an inpatient. So we've found it's really difficult. It's the dysphagia menu is unfortunately at the moment at Salford and probably elsewhere is really limited. So I mean, if there's patients maybe on a dysphagia diet for weeks, if not months, if they have this poor swallow, and it just gets really repetitive. There's the psychological element around that as well. So getting used to a texture modified diet, if it's something that's going to be long term, is challenging. If it's something they're going to be discharged on and on long term in the community, implications in terms of eating out and mental health implications with that can be really, really challenging. And as I say, general enjoyment of foods and drinks that they enjoyed before can be a really big step for people. So it's as I say, this particularly puts people at longer term nutritional kind of risk. So it's just being mindful of that, to be honest, that it's likely that people might require kind of community dietetic follow up to monitoring community. And as I mentioned before, suitable nutritional supplement drinks sometimes is maybe not the kind of education in the community about correct supplement drinks for particular patients on thickened fluid. So just being a bit careful with that and always checking if need be. Yeah, and I've just said there, as I say, it can be really, really challenging, particularly something like a level 4 pureed diet long term, meeting nutritional needs and not becoming fatigued by that. So as I say, always refer to dietitians if you need some support with trying to meet nutritional needs.
So just to move on to the standards, with the evidence that kind of Kerry's presented in terms of the background, we have national frameworks that we can refer to in terms of guiding us with nutritional care. And the two big documents that people be aware of are the NICE guidelines and the Rcp guidelines. And so what we've done is we've broken down different components of nutritional care and given a summary really of what is advised within those guidelines. So for nutritional screening, and obviously we heard Kerry talk about some of the available tools and the importance of nutritional screening. It's just to recap that both NICE and Rcp advocate that all stroke patients should be screened using a nutritional screening tool upon admission. And it should be done by a healthcare professional who's received adequate training and is competent in undertaking that screening. SNAP, this is the only area really that we would pull out any kind of recommendation from SNAP, because the only nutritional standard within SNAP sits within a discharge domain, and it states that for patients that have scored highly on a nutritional risk screening tool should be seen by a dietitian by discharge. So that is supporting the use of nutritional screening. And then just to share kind of what happens at a local level. So at Salford Royal, there is some discussion happening about wider with the merger that's happening with Pennine and the Northern Care Alliance. We've always had a standard of our screening tool being done within 6 hours of admission. And I'll talk a little bit about some of the data we pulled during our quality improvement project that kind of highlights the challenges of that in the stroke population. And it is something that's being reviewed within our trust. The second area that we looked at was the guidelines around management of patients that are nil by mouth or requiring artificial feeding. So it's predominantly tube feeds are used when someone's nil by mouth, but also if intake is significantly reduced. So again, both NICE and Rcp have quite similar standards with regards to this, in that there should be an appropriate nutrition support plan in place for these patients. And the key thing to pull out is this 24-hour target. So if it's clear within 24 hours of admission that the patients are not going to be able to meet their nutrition, hydration, and potentially medication needs orally, then the artificial feeding should be commenced within that time period. Then in terms of malnutrition risk, this overlaps obviously with nutritional screening, but again, both documents highlight the importance of having nutritional screening and monitoring, and they're talking a little bit more detail about appropriate specific nutrition support care plans. And then just to pull out what NICE have said, which kind of links in with what Kerry described when she took you through an example of a nutritional screening tool, to be aware that there are additional components with the stroke population as to why those tools can't really be used in isolation. So particularly areas of concern such as dysphagia and reduced ability to self-feed. Then a little bit about longer term feeding. This isn't kind of covered in as much detail, but within Rcp, they do kind of give some guidance about when gastrostomy feeding, so either PEG or RIG, should be considered. Both Rcp and NICE talk about consideration if there are difficulties, ongoing difficulties with tolerating nasogastric tubes, but Rcp also do give a bit of a time guidance in that if a patient is unable to meet their nutritional and fluid medication needs by 4 weeks from the onset of stroke, then gastrostomy should be considered. Then finally, with regards to post-acute care, it's really the Rcp document that talks about this in detail, and this is discussed really within the kind of umbrella subject of secondary prevention advice. So diet obviously plays a part in that alongside other lifestyle factors. So we will talk in a little bit more detail in the next slide about the up-to-date evidence about specific dietary messages that should be given if you are providing secondary prevention advice. But just to highlight, we know across Greater Manchester, it does vary in terms of community dietetic support to stroke patients. So we know that some of the funded community stroke teams will have a dietetic post within that team, some don't, and then general dietetic services can vary across Greater Manchester. Obviously, it doesn't have to necessarily be a dietitian that provides the secondary prevention advice, and quite often it's done in a bundle with the other lifestyle factors. But just to say, if it's a particularly challenging patient, if there are other comorbidities, if it's somebody that you've got concerns about, then don't hesitate to refer to the dietitian so they can get that individualised assessment.
Yeah, so just to touch on a bit more, actually, kind of what Christina's mentioned there about secondary advice, some of the key messages really would be things kind of like the weight management, following a healthy, balanced diet, being careful with salt intake, looking at kind of fat intake, particularly saturated fat, and swapping them for the mono or polyunsaturated fat, looking at high levels of alcohol, so healthy levels of normal alcohol consumption levels, and other lifestyle factors such as exercise. But echoing really what Christina said, I mean, unfortunately, there's a lot of information online, quite confusing information on the internet and elsewhere these days. So if there are kind of is confusion or concerns, always just to seek professional advice and refer to a dietitian.
So the next part of the presentation today is to share some local findings from the work that we've conducted at Salford. So hopefully it's been helpful to kind of set the scene in terms of the background and the evidence that we have with regards to nutritional management in stroke patients. And just to kind of share really what led to the formation of us having a stroke-specific nutrition pathway at our trust and what we've learned from those areas of work. So we found kind of over the last 4 to 5 years, we had a series of serious incidents and investigations where the common theme really was around a delay to initiate and sustain nutrition. So for all the patients that this applied to, they were patients who were nil by mouth. And there were quite common things that I think would happen in any stroke unit, but once you started to add certain things up, it obviously led to a length of time where there was a delay in feeding. And some of the things that we found when we kind of drilled down and looked at what were the things that were occurring that led to these issues were around things such as a culture of perhaps giving patients time to see if their swallow improved. So thinking back to the Rcp and NICE standard to initiate artificial feeding within 24 hours if the patient's unable to meet their needs orally, that wasn't always being applied because there perhaps was some hope that the patient would pick up after a 24-hour period. And also that could be applied if it was quite tricky in accessing, so sustaining enteral access. So if somebody was obviously pulling out their NGs and it was quite tricky. Then when we have patients like that, where there are issues with NG placement, which we know can be a common occurrence, we found that there perhaps was just variable knowledge about how to escalate when that goes on for a certain period of time. And if bedside placement is difficult, when and how do we involve services such as ENT and radiology? That also led to some kind of miscommunication, misunderstanding about when we apply things like the dolls, the posy mitts, one-to-one specialing to support with a nasogastric tube. And obviously in our trust, we have the policy where if people are pulling out NG tubes, this kind of variable opinion, but they wouldn't be classed as suitable for a bridle. So it's what do we do in those circumstances? And so I guess for all of those things, there was some miscommunication as a team. And then I guess sort of last resort when enteral access is quite difficult is around the indication for parenteral nutrition. So again, we found there was some mixed knowledge around that and particularly around the use of parenteral nutrition out of hours. As mentioned, this led us to undertake a piece of work where we developed a stroke-specific nutrition pathway. And we've tried to make this as user-friendly as possible. And obviously the evidence that we have both locally and from those national guidelines underpin this pathway, and they're our benchmark. So it's essentially a 4-day process. So it acts as a flowchart that can be used by any member of the team involved in this decision making and the delivery of nutritional care. And our view was that it would work really well to kind of complement kind of a ward round or MDT, and it can be referred to and it's easy use. So I won't go through in too much detail, but we've sort of highlighted on each day the steps that should be taken and the things that should be considered. And it gives some guidance on what to do if problems are experienced on any of those days. So that's not captured necessarily on this slide, it's in the wider document. But for example, on day 2, we've given specific guidance of if you're struggling to establish enteral access, what to do. So we've set a target that it should be 3 attempts at an NG, you know, in one kind of sitting, and that should be done a maximum of 2 times within a day. And obviously, if it's causing the patient distress or it's particularly difficult, that's when you would then escalate. And we've obviously got agreed pathways with ENT, radiology, the nutrition team in our trust, and it just makes clearer about how and when something like parenteral nutrition would be accessed. It does take us through beyond day 4 to when we should start to consider longer term feeding. Again, while we were doing a nutrition pathway, it's kind of pull the evidence that we have from the RCP. And we've just tried to trigger that those discussions start to be kind of considered really after 3 weeks after the onset of stroke, to really kind of start that process, particularly if there are additional steps such as mental capacity assessments, best interest meetings, and then obviously logistically internally with referring to endoscopy. So just a little bit about long-term feeding outside of Salford and just sort of up-to-date evidence. Obviously, we've got the standard from the RCP about the time frame to consider gastrostomy discussions. We find kind of in clinical experience that obviously really is patient dependent and it varies. And I think as long as there's a good MDT presence and discussion about these things and it's not kind of left too long, that, you know, locally policies will be followed. And each trust obviously will have their own pathway. Just to highlight a couple of documents that link into longer term feeding. So I'm sure most people are aware of the British Medical Association guidelines around clinically assisted nutrition and hydration. So it's a 100-page document, so it's got a lot of information in. And this obviously refers to you know, in terms of kind of like complex ethics really with artificial feeding, and it's applicable for any patients that lack capacity, but it obviously does cover about the withdrawal of clinically assisted nutrition and hydration. And I guess in stroke, perhaps for minimally conscious patients, that could be applicable. And it's a useful document to be aware of, even early on in that patient journey, to when first discussing artificial feeding with kind of family. And then a newer document that some may be aware of, but just to highlight because again, it's quite relevant to our practice working within stroke. So the RCP guidance around essentially a practical guide to support patients who have eating and drinking difficulties, and there is a focus with regards to ends of life in that document. So we've put the links to both of those. So then back to our work at Salford, obviously linking into the incidents and the learning that we took from that, there was another piece of work that was conducted last spring. And the predominant reason for conducting this work was to try and get some data to support a dietetic business case internally at Salford. But while we were taking this piece of work, we wanted to look at an opportunity to evaluate nutritional care on our acute stroke unit. So it was looking at the impact of a full dietetic service. So we had 2 dietitians that were based on our acute stroke unit for a week. And then the objectives that we looked at more specifically was to try and look at what was happening with nutritional screening and what current practice was with regards to referral to dietetics and escalation of nutritional issues, and to see obviously by having more dietetic presence what difference we made with regards to outcomes such as the days it took to meet a full nutritional requirements for a patient. So won't go through in too much detail, but we're just happy that this is here and you can refer to if interested. But essentially what we did to undertake this piece of work is we audited a baseline, so kind of based on current dietetic funding and a usual week, and we collected data, and then we collected the intervention data when the 2 dietitians were based on the unit. There was some variation in obviously age and gender, and then from a clinical perspective, we had some more medical outliers during the intervention week, but they were managed by the stroke team. So we felt still looking at kind of the application of the stroke nutrition pathway was applicable. And then BMI range, I guess just to highlight within the baseline week, for 88% of patients, we weren't actually able to establish what their body mass index was. And that was predominantly due to a lack of either weight or height measurement, meaning we didn't have a calculated BMI, which obviously then leads us to know that nutritional screening can't have been accurate. Another opportunity that we had from doing this piece of work was to look at the patients on oral diet and fluids. So Obviously, some of the work that we'd done recently at Salford had been focused more on patients that were nil by mouth, but we wanted to get an idea of what this cohort looks like in terms of nutritional requirements when they are being fed through the oral route. So we were able to capture kind of the incident rate of requirement for texture modified diet and fluids, and also what the varied levels were. So that is going to vary any different day in stroke, because there'll be different recommendations in place for the patients that are present on the ward. But it just kind of gives some further evidence really to what Kerry had discussed earlier on in the presentation about the high incident rate of dysphagia and how that's such a challenge, that when we looked at dietetic input for the intervention week when we were based on the unit, we essentially ran a blanket referral system where we screened out. So we assumed everybody needed a dietitian until we assessed otherwise. And for nearly 50% of patients, even though they were requiring the oral route, they still had dietetic needs. So there were still issues in terms of meeting their nutritional requirements. So looking at the specific objectives and what the piece of work was able to tell us about our outcomes, looking at nutritional screening and the management of this, we were able to look at if the local target, which is 6 hours at Salford, was met. And we found even by having the dietitians present, we weren't able to make an improvement on that. So over 60% of patients in both groups, we didn't meet the 6-hour target. And I think we found kind of practically as a unit, that's a real challenge with an acute stroke patient. And we'll kind of come on to kind of further discussions around that. I guess then it was looking at, well, what happens with weight during the whole admission? Are we able to get a weight for the patients? And there was a slight improvement by having the dietitians present to perhaps drive that and requesting the weight. So it was up slightly. But ultimately, because of issues, I think, in accessing weight and height, we found that the nutritional screening scores were inaccurate. But by having the dietitians present, we would rescreen, so we repeated must, and we were able to get 98% of patients with an accurate score by being present and supporting and recalculating that screening score. Another component of nutritional assessment and monitoring, with everything that we've talked about the risk of malnutrition and dehydration, is having completed food and fluid charts. And again, by having dietetics present, we weren't necessarily able to make a difference on this, but it was really helpful that we were able to get this data, because that's something that we're taking forward to try and improve. That it's obviously a huge challenge that I don't think is just present on our unit, but it just shows everything we've talked about today, how important it is to have that, but practically it does seem to be an issue in having that completed routinely. So an extension of that first objective with regards to nutritional screening, and when we break down in a bit more detail about the length of time it took to actually get a first weight for a patient, we were able to bring that average down by the dietitians being present. So again, we feel that's just by having that increased presence of somebody leading on nutrition and requesting and supporting with the weight. So where possible, the dietitians would help to weigh the patients. And then looking at kind of what happened in clinical practice in the management of nutrition for patients on the unit at that time. Obviously, there was a difference in the intervention that the dietitians were based on the unit, and there was a blanket referral system. Usual practices that the unit would refer to us, and we would triage and take on the patients. So again, looking at the average length of time that a patient was nil by mouth before they were referred to a dietitian, and we were able to bring that down significantly in the intervention stage. And just to show, I think this definitely mirrors what we find kind of on a regular basis. It can really vary, so anything up to 7 days before somebody has been referred. And so I guess just to highlight, in those cases, that patient likely will have been on an out of hours feed prescription that wouldn't have met their full nutritional needs. The next objective was, again, us looking at kind of current practice in a bit more detail, and 3 main components. So how many days it took for a decision to be made about artificial feeding, knowing that we've got that standard from Rcp and NICE that within 24 hours of admission to try and establish feeding if unable to use orally. How many days it took for that feeding to be commenced, and how many days that patient was on that out of hours feed prescription. So again, unsurprisingly, those averages were brought down by, again, having increased dietetic presence. And I guess just to say that by us being there every day and taking on patients, we could get involved at quite an early stage. So even if the patient was nil by mouth, didn't have the tube yet in place, there are things that we can be doing, such as getting nutritional baseline, weight history, calculating their calorie, protein requirements, and have a prescription ready to go once the tube is in sight. And then again, unsurprisingly, there was a difference in this component. So we looked at how many days from referral until a dietitian was able to see the patient. So essentially, in the intervention period, we were providing gold standard levels of care where we were able to respond to any requests for input promptly. And so there was a much improved time to see the patient, whereas it could really vary dependent on our staffing, because stroke is managed within an overall caseload. So there was a significant difference between the two groups. And then an extension of that is how many days it took for full nutritional requirements to be met. So I think, unsurprisingly, because we were able to reduce down the time it took to make decisions about feeding routes, initiating feeding, and dietetic input, we were able to improve the number of days. So it was reduced down, meaning that patients were less reliant on an out-of-hours feed prescription and able to get a more tailored plan promptly. So the takeaway messages that we found as a team from that piece of work, and things that are really ongoing at Salford, because it has led to the formation of a stroke nutrition working group, is that there is probably a discussion locally to be had, and I think this will vary in different trusts, about how your nutritional screening policy works for acute stroke patients. So there are discussions happening within our trust about that 6-hour target, but I guess even if you had a 24-hour target, thinking about stroke patients and how acutely unwell they are in that first day, and if that is massively affecting how accurate you can get that nutritional screening score, it's perhaps worth considering, and I'm sure some places already do this, that you perhaps repeat the screening score for a stroke patient. Because I think, like Kerry said, having that period where someone's nil by mouth doesn't help things, and it can lead to confusion with how their screening tools are designed. We found massive benefits, which I hope we demonstrated from the data, about the presence of having dietetics based on the unit. And we think, because of the risks that we've highlighted today with regards to dysphagia and malnutrition, that really all stroke patients should be screened out, and there should be a plan in place. And that only really can be supported by having dietitians present. Obviously, it's not just about dietitians. So as we found from kind of our incidents and the pathway that we developed, nutrition is really reliant on good MDT working and communication. So that's where our working group has been really helpful. And it's trying to really, I think, drive home that we want nutrition to be up on the agenda. So it's not just a case of, is the NG in, what are they being fed, have they been seen by the dietitian? So it's kind of really having that presence on ward rounds. So we're looking at how it fits in our ward round document template, and trying to utilise things more like huddles. And then I know experience from other areas where we've done some QI work before, we've utilised things such as the nutrition ward round, because if there isn't a lot of time in the main ward round to go through that level of detail, it could be your run test of change, where you have relevant people like maybe dietitian Salt, member of the medical nursing team, and you kind of go around and do a quick recap on what's happening with nutritional care. And we were able to pull some data, as we've said, about the prevalence of dysphagia and the requirement for modified texture diet and fluids. And so that's really important that that group is given the focus, as well as the nil by mouth tube fed patients, to ensure that there is adequate monitoring in place.
Yeah, and so just summarising really with some key considerations. So we've kind of found from our research and finding how vulnerable stroke patients are, unfortunately, in terms of nutrition and dehydration kind of risk, the high risk group. And as I said, nutritional screening and management plans early on is really important, and ongoing monitoring in the community. Secondly, management dysphagia. As I say, the research indicates how prevalent dysphagia is, and we've found kind of following a textured modified diet, and the research indicates that it's really hard often meeting nutrition and hydration needs on a textured modified diet, and that's where, as I say, dietitians and speech and language therapy teams are a really key part of that. So please do refer over us for monitoring support with a textured modified diet. Thirdly, kind of stroke specific nutritional guidelines, and just really querying whether a more stroke specific nutritional screening tool would be useful. The MUST screening tool is great, it's easy to use, it's a step-by-step approach. However, things such as dysphagia, ability to self-feed, other aspects of feeding that are the key barriers to nutrition. They all need to be considered in the overall nutritional screening, really, nutritional care of a patient. Also, as I touched on there as well, secondary prevention programmes, the importance of diet and monitoring in a referring community is important. As I say, it's quite varied really, dietetic support in the community for secondary prevention. And there's lots of information out there on the internet which can be quite conflicting and confusing, but please do approach us or refer, sorry, to dietitians if there's any confusion really about kind of longer term and secondary prevention post-stroke. Great, and we just got a list of references there. We can circulate these slides so you can access them obviously after the presentation. And thank you for listening and thank you for the time. Please do come on the day with any questions, and we've just got our email address here if you want to kind of get in touch after the presentation with any queries. Do get in touch. Thank you.